Welcome to Nurse's Lab. Welcome back to the channel. Today we're diving deep into the 2025 American Heart Association Pediatric Advanced Life Support Guidelines, developed with the American Academy of Pediatrics. These updates reshape how we approach pediatric resuscitation, from pre-arrest recognition to intra-arrest management, post-cardiac arrest care, and long-term survivorship. Whether you're a nurse, physician, paramedic, educator, or student, this session will give you a clear, practical, and clinically relevant breakdown of what's new, what's changed, and what it means for your practice. 2025 PALS reinforces that the best resuscitation is the one you prevent. Key updates include stronger emphasis on early warning scores and deterioration detection, clearer guidance on managing respiratory distress, shock, and altered mental status, encouragement of rapid response systems and team activation, focus on family-reported concerns because parents often notice subtle changes first. The message is simple. Kids rarely arrest suddenly. They show signs, and we need to catch them. In this session, we'll explore the full spectrum of pediatric resuscitation, from the moment a child collapses through the intensity of cardiac arrest and into the critical hours, days, and months that follow. We'll begin with the core resuscitation science, ventilation and advanced airway strategies, drug administration during cardiac arrest, energy dosing and defibrillation principles, measuring CPR physiology and quality, the role of extracorporeal CPR, post-cardiac arrest care treatment and monitoring, Neuro prognostication following cardiac arrest, survivorship and long-term recovery, and the essential role of family presence during resuscitation. We'll also examine the evaluation of sudden unexplained cardiac arrest in children. Then, we transition into specialized pediatric emergencies that demand precision and expertise, management of septic shock, safe and effective intubation, treatment of bradycardia, various tachyarrhythmias, care for myocarditis and cardiomyopathy, resuscitation of children with single ventricle congenital heart disease, management of pulmonary hypertension crises, and the unique approach required for traumatic cardiac arrest. Together, these topics form the backbone of modern pediatric resuscitation, a blend of physiology, teamwork, and compassionate care. Let's begin. Before diving into the pediatric advanced life support, let's have a brief look into the 2025 AHA Updated Unified Cardiac Arrest Chain of Survival. The cardiac arrest chain of survival is the roadmap that saves lives. It outlines the critical actions that must happen quickly, clearly, and in the right order to give every patient the best chance of survival. From early recognition and rapid activation to high-quality CPR, timely defibrillation, advanced care, and coordinated post-arrest treatment, each link strengthens the next. When the chain is strong, survival rises. When even one link breaks, outcomes fall. This is the foundation of modern resuscitation, and every second counts. Now, let's move on to the 2025 key updates on PALS. First, let's discuss about ventilation and advanced airway strategies during CPR. During CPR, ventilation is all about balance. Oxygenate without overventilating. Start with strong bag mask ventilation, protect compressions, and only place an advanced airway when it won't slow you down. Smart ventilation saves lives. 1. For infants and children experiencing out-of-hospital cardiac arrest, using bag mask ventilation is considered appropriate instead of performing advanced airway interventions such as tracheal intubation or placement of a supraglottic airway. 2. For infants and children experiencing cardiac arrest in the hospital without an advanced airway, It may be appropriate to use bag mask ventilation or consider advanced airway techniques, such as tracheal intubation or the placement of a supraglottic airway. 3. During CPR for infants and children who have an advanced airway in place, it is advisable to aim for a ventilation rate of 20 to 30 breaths per minute, delivering 1 breath every 2 to 3 seconds, while considering the child's age and clinical condition. Avoiding hyperventilation as it can negatively impact hemodynamics. Next, let's discuss about drug administration during cardiac arrest. Drug administration during cardiac arrest is all about precision and timing. The 2025 guidelines prioritize rapid IV or IO access, streamlined dosing, and using medications only when they support high-quality CPR and defibrillation. In cardiac arrest, drugs don't save lives alone, they amplify the effectiveness of good resuscitation. In this, first, let's discuss about drug administration methods during cardiac arrest. 1. Prompt establishment of IV or IO access is advised for administering medications to infants and children experiencing cardiac arrest. 2. When treating infants and children experiencing cardiac arrest in the hospital without an advanced airway, healthcare professionals should select the initial vascular access route, whether it be IV or IO, according to which option is most readily available, the team's proficiency, and the speed with which access can be established. Next, let's see about drug administration during cardiac arrest. 1. For infants and children experiencing cardiac arrest with a non-shockable rhythm at onset, prompt administration of the first dose of epinephrine is advisable. 2. For infants and children experiencing cardiac arrest with an initial shockable rhythm, it may be reasonable to give epinephrine after 2 unsuccessful defibrillation attempts, or earlier if rapid defibrillation cannot be performed. 3. For infants and children experiencing cardiac arrest in any environment, it is considered appropriate to give epinephrine every 3 to 5 minutes until return of spontaneous circulation, ROSC, occurs. 4. For infants and children experiencing shock-refractory ventricular fibrillation or pulseless ventricular tachycardia, the use of either amiodarone or lidocaine can be considered as a treatment option. 5. Sodium bicarbonate should not be routinely administered to infants and children experiencing cardiac arrest unless specific situations arise, such as sodium channel blocker toxicity or hyperkalemia. 6. Calcium should not be routinely administered to infants and children experiencing cardiac arrest unless specific situations, such as hypocalcemia, calcium channel blocker overdose, or hyperkalemia are present. Next, let's see about weight-based dosing of resuscitation medications. 1. For infants and children experiencing cardiac arrest with an initial non-shockable rhythm, it is advisable to give the first dose of epinephrine at the earliest opportunity. 2. In cases of cardiac arrest in infants and children with an initial shockable rhythm, giving epinephrine after 2 defibrillation attempts may be appropriate, or earlier if immediate defibrillation cannot be performed. 3. For infants and children experiencing cardiac arrest in any environment, it is considered appropriate to give epinephrine every 3 to 5 minutes until return of spontaneous circulation, ROSC, occurs. Energy dose for defibrillation in cardiac arrest. The 2025 guidelines sharpen dosing recommendations to ensure fast, effective defibrillation with minimal interruptions. In pediatric arrest, every joule counts, and delivering the correct energy at the right moment is essential for restoring a perfusing rhythm. 1. For infants and children who suffer cardiac arrest due to ventricular fibrillation or pulseless ventricular tachycardia, an initial defibrillation dose of 2 to 4 joules per kilogram using either monophasic or biphasic energy is considered appropriate. To simplify instruction, starting with a dose of 2 joules per kilogram is also reasonable. 2. For infants and children who suffer cardiac arrest with persistent VF or PVT, it is reasonable to deliver additional defibrillation shocks at 4 joules per kilogram using either monophasic or biphasic energy. If needed, higher energy doses may be used, but should not exceed 10 joules per kilogram or the maximum adult dose. 3. For infants and children undergoing cardiac arrest with persistent VF or PVT, it may be preferable to administer a single defibrillation shock using either monophasic or biphasic energy instead of multiple consecutive shocks. After delivering the shock, chest compressions should be promptly resumed. Next, let's discuss about measuring CPR physiology and quality. High-quality CPR isn't guesswork, it's measurable. The 2025 guidelines shift resuscitation toward real-time physiology using ETCO2, arterial pressure, and perfusion markers to guide every compression. When we measure CPR, we don't just push harder, we push smarter, and survival improves. 1. For infants and children undergoing CPR with continuous invasive arterial blood pressure monitoring, it is appropriate for healthcare providers to use diastolic blood pressure as an indicator of the child's response to resuscitation. 2. For infants and children undergoing CPR who have invasive airways in place, ETCO2 monitoring can be considered as a method to assess the quality of chest compressions. 3. For infants and children undergoing CPR who have continuous invasive arterial blood pressure monitoring, it may be appropriate for healthcare providers to aim for a diastolic blood pressure of at least 25 millimeters of mercury in infants and at least 30 millimeters of mercury in children aged 1 year and older. 4. The effectiveness of using near-infrared spectroscopy to non-invasively monitor cerebral oxygenation during CPR in infants and children remains uncertain. 5. Using CPR feedback devices in infants and children may be appropriate to help ensure optimal chest compression rate and depth, especially when integrated into an ongoing resuscitation quality improvement program. 6. If trained staff are present, echocardiography can be used to detect treatable causes of cardiac arrest in infants and children, including cardiac tamponade and insufficient ventricular filling. However, the advantages of this approach must be balanced against the negative effects of pausing chest compressions. 7. An isolated ETCO2 cutoff value should not be solely relied upon to determine when to discontinue resuscitative efforts in infants and children. What are the updates on extracorporeal cardiopulmonary resuscitation? Extracorporeal CPR is the ultimate rescue strategy for children in refractory cardiac arrest. The 2025 guidelines sharpen when and how to use it, emphasizing rapid identification, specialized centers, and coordinated team activation. In the right patient and the right system, eCPR can turn a non-survivable arrest into a recoverable event. eCPR can be an option for infants and children experiencing in-hospital cardiac arrest that does not respond to standard CPR, provided they are in clinical environments equipped with established eCPR protocols and experienced teams. Next, let's discuss about post-cardiac arrest care, treatment, and monitoring. Post-cardiac arrest care is where survival becomes recovery. Once a pulse returns, the focus shifts to protecting the brain, stabilizing the heart, and preventing secondary injury. This phase is critical because what we do after ROSC often determines long-term outcomes. Firstly, let's see about post-cardiac arrest targeted temperature management. 1. For infants and children who do not regain consciousness after experiencing cardiac arrest, it is advised to implement ongoing central temperature monitoring. 2. For infants and children who continue to be comatose after experiencing cardiac arrest, it is advised to prevent central temperatures from exceeding 37.5 degrees Celsius. 3. For infants and children between 24 hours and 18 years of age who remain comatose after IHCA or OHCA, it is reasonable to use a 5-day course of targeted temperature management, whether 32 degrees to 34 degrees Celsius, followed by TTM of 36 degrees to 37.5 degrees Celsius, or only TTM of 36 degrees to 37.5 degrees Celsius. Next, let's move on to post-cardiac arrest blood pressure management. Following cardiac arrest in infants and children, it is advised to keep both systolic and mean arterial blood pressure above the 10th percentile for the patient's age. Following cardiac arrest in infants and children, it is advised to use continuous arterial pressure monitoring to detect and manage hypotension, provided suitable resources are accessible. Next, let's see about post-cardiac arrest oxygenation and ventilation management. Following cardiac arrest in infants and children, it may be appropriate to aim for normal oxygen levels tailored to each patient's individual medical needs. Following cardiac arrest in infants and children, it may be appropriate to reduce oxygen levels to achieve an oxyhemoglobin saturation within the range of 94% to 99%. Following cardiac arrests in infants and children, it may be advisable to adjust PaCO2 levels based on the patient's individual underlying condition while avoiding prolonged periods of hypercapnia or hypocapnia. Now, let's discuss about post-cardiac arrest electroencephalography monitoring and seizure treatment. Continuous electroencephalography monitoring is advised when resources permit for identifying seizures following cardiac arrest in infants and children who remain encephalopathic. Clinical seizures occurring after cardiac arrest in infants and children should be promptly managed with appropriate treatment. Managing non-convulsive status epilepticus following cardiac arrest in infants and children should involve expert consultation to ensure appropriate treatment decisions. Neurological prognostication after cardiac arrest. Neurological prognostication after cardiac arrest requires patience, precision, and a multimodal approach. The 2025 guidelines emphasize delaying early predictions and relying on multiple assessments, not a single test or early exam. First, let's discuss about multimodal prognostication following cardiac arrest. Healthcare professionals are advised to use a variety of assessment methods when evaluating neurological outcomes, whether favorable or unfavorable, after resuscitation from cardiac arrest in infants and children. Next, let's discuss prognostication using clinical examination following cardiac arrest. The role of cough or gag reflexes, as well as responses to pain, in predicting a favorable or unfavorable neurological outcome at any point after cardiac arrest in infants and children remains uncertain. The predictive value of motor responses to stimuli for determining a positive or negative neurological outcome at any stage following cardiac arrest in infants and children remains unclear. The reliability of using the Total Glasgow Coma Scale, or the Glasgow Motor Score, to predict a favorable neurological outcome at any point after cardiac arrest in infants and children remains uncertain. When considered alongside other prognostic factors, observing bilateral pupillary light reflexes within the first 12 hours after cardiac arrest in infants and children can reasonably be used to indicate a favorable neurological outcome. Considering other prognostic factors, the lack of bilateral pupillary light reflexes observed between 48 and 72 hours following cardiac arrest in infants and children can reasonably be used to indicate a poor neurological outcome. It is not advised to use the lack of pupillary light reflex within the first 24 hours after cardiac arrest in infants and children to predict an unfavorable neurological outcome. It is not recommended to use the Glasgow Coma Score within the first 24 hours after cardiac arrest in infants and children to predict an unfavorable neurological outcome. Next, let's discuss about prognostication using biomarkers following cardiac arrest. 1. When considered alongside additional prognostic factors, a plasma lactate level below 2 millimoles per liter within the first 12 hours following cardiac arrest in infants and children may help indicate a positive neurological outcome. 2. The reliability of neuronal biomarkers such as S100B and neuron-specific enolase in predicting either positive or negative neurological outcomes following cardiac arrest in infants and children remains uncertain at any stage after the event. 3. It is advised against relying on blood lactate levels following cardiac arrest in infants and children as an indicator for predicting poor neurological outcomes. 4. Using blood lactate levels after cardiac arrest in infants and children is not recommended as a reliable marker for forecasting adverse neurological outcomes. Next, let's see about prognostication using electrophysiology following cardiac arrest. 1. When considered alongside additional prognostic factors, it is appropriate to utilize EEG within 72 hours following cardiac arrest in infants and children to help determine whether the neurological prognosis is favorable or unfavorable. 2. When considered alongside other prognostic factors, identifying a continuous or normal EEG background within the first 72 hours following cardiac arrest in infants and children can be used to support a positive neurological outcome. 3. Considering other prognostic factors, observing sleep spindles or stage 2 sleep patterns on EEG within 12 to 24 hours following cardiac arrest in infants and children may be used to suggest a positive neurological outcome. 4. When considered alongside other prognostic indicators, observing EEG reactivity within 6 to 24 hours following cardiac arrest in infants and children may help support a positive neurological outcome. 5. The presence of status epilepticus or abnormal EEG patterns within 24 to 72 hours after cardiac arrest in infants and children may indicate a poor neurological outcome. 6. The predictive value of attenuated, isoelectric, or flat EEG patterns, as well as the occurrence of myoclonic status epilepticus at any stage following cardiac arrest in infants and children, remains uncertain in determining an unfavorable neurological outcome. 7. EEG findings such as seizures, lack of sleep architecture, abnormal background, or absence of reactivity and variability after cardiac arrest in infants and children are not recommended to predict poor neurological outcomes. 8. The lack of burst suppression, burst attenuation, generalized periodic epileptiform discharges, attenuated, isoelectric, or flat EEG at any time after cardiac arrest in infants and children should not be used to predict a favorable neurological outcome. 9. The lack of clinical or electrographic seizures, status epilepticus, or myoclonic seizures at any time following cardiac arrest in infants and children should not be used as evidence for a favorable neurological outcome. Next, let's see about prognostication using neuroimaging following cardiac arrest. 1. When considered alongside other prognostic factors, a normal brain MRI performed between 72 hours and 2 weeks following cardiac arrest in infants and children can reasonably be used to indicate a positive neurological outcome. 2. When considered alongside other prognostic factors, an abnormal brain MRI demonstrating a significant ischemic burden at 72 hours or more following cardiac arrest in infants and children may reasonably be used to support an unfavorable neurological prognosis. 3. Considering other prognostic factors, performing a CT scan that shows loss of gray-white matter differentiation within 24 hours after cardiac arrest in infants and children may be appropriate to help support an unfavorable neurological prognosis. 4. It is not advised to use a normal brain CT scan within the first 48 hours after cardiac arrest in infants and children as evidence for a positive neurological outcome. Post-cardiac arrest recovery is more than survival. It's about restoring a child's life, identity, and future. The 2025 guidelines highlight survivorship as a critical phase of care, emphasizing rehabilitation, neurocognitive follow-up, emotional support, and family-centered recovery. Infants and children who have survived cardiac arrest should be assessed to determine their need for rehabilitation services. It is appropriate for infants and children who have survived cardiac arrest to undergo assessment of their physical, cognitive, and emotional needs to inform their follow-up care during the first year after the event. Family presence during resuscitation. Family presence during resuscitation is no longer an afterthought. It's a supported, structured part of modern pediatric care. The 2025 guidelines emphasize that families can remain at the bedside when appropriate, guided by a dedicated team member who ensures safety, clarity, and compassion. Family members ought to be given the opportunity to be present during the resuscitation of their infant or child. When resuscitating an infant or child in the presence of family members, it is advisable to assign a specific team member to offer comfort, respond to questions, and support the family throughout the process. If having family members present is believed to hinder the resuscitation efforts of the infant or child, they should be courteously requested to step out. Evaluation of sudden unexplained cardiac arrest. Sudden unexplained cardiac arrest in a child demands a thorough, systematic evaluation. When no clear cause is found at the bedside, the 2025 guidelines emphasize a structured approach that includes cardiac imaging, rhythm analysis, metabolic and genetic testing, and multidisciplinary review. For sudden unexplained deaths in children, a thorough autopsy by an experienced cardiovascular pathologist is advised, with biological samples preserved for genetic testing of inherited heart conditions. If no cause of death is found in sudden unexplained deaths among infants and children, post-mortem genetic testing is advised, particularly when inherited cardiac disease is suspected and resources permit. If an autopsy fails to determine the cause of death or is not conducted in cases of sudden unexplained death among infants and children, it is advised that immediate family members consult with a healthcare provider or a specialized center experienced in inherited cardiac conditions and genetic counseling for cardiac disorders. For infants and children who survive sudden unexplained cardiac arrest, take a thorough medical and family history, review prior ECGs, and refer to a cardiologist experienced in inherited cardiac diseases. Beyond the core science of resuscitation lies a group of pediatric emergencies that demand precision, speed, and deep physiological understanding. These are the high-risk conditions where standard algorithms aren't enough, where every decision must be tailored to the child's underlying disease, hemodynamics, and vulnerability. In this section, we explore the specialized emergencies that challenge even experienced clinicians. Let's discuss those one by one. First, let's discuss about management of shock. Shock in children is a race against time, a rapid collapse of perfusion that demands immediate recognition and targeted intervention. The 2025 guidelines emphasize a physiology-first approach, identify the type of shock, correct the underlying cause, and support circulation with precise fluids, vasoactives, and continuous reassessment. In management of shock, first, let's see about fluid resuscitation and management of septic shock. 1. After each fluid bolus, healthcare professionals should re-evaluate infants and children to determine their response to the fluid and check for any indications of volume overload. 2. Isotonic crystalloids or colloids are both suitable options for the initial fluid resuscitation of infants and children. 3. Both balanced and unbalanced fluids may serve as suitable options for resuscitation in infants and children. 4. For infants and children experiencing septic shock, it is appropriate to provide fluid in increments of 10 milliliters per kilogram or 20 milliliters per kilogram, ensuring frequent reassessment throughout the process. 5. For infants and children experiencing fluid refractory septic shock, starting with epinephrine or norepinephrine as the initial vasoactive infusion is considered appropriate. 6. For infants and children experiencing cardiac arrest in the context of sepsis, using the standard PALS algorithm is considered reasonable, rather than adopting a sepsis-specific cardiac arrest approach. 7. In infants and children with septic shock who do not respond to fluid resuscitation and need vasoactive medications, the use of stress-dose corticosteroids may be considered. 8. If epinephrine or norepinephrine cannot be accessed, dopamine may be used as an alternative in infants and children experiencing fluid refractory septic shock. Next, let's discuss about management of cardiogenic shock. 1. Prompt consultation with specialists is advised for infants and children experiencing cardiogenic shock. 2. In cases of cardiogenic shock in infants and children, administering an inotropic infusion such as epinephrine, dopamine, dobutamine, or milrinone may be considered appropriate. Next, let's see about management of traumatic hemorrhagic shock. For infants and children experiencing hypotensive hemorrhagic shock due to trauma, it is appropriate to use blood products for ongoing volume resuscitation when available, rather than crystalloids. Next, in specialized emergencies procedure, let's discuss about intubation. Intubation in pediatric emergencies demands precision, preparation, and perfect timing. The 2025 guidelines emphasize hemodynamic stability, uninterrupted compressions, and a team-based approach to securing the airway. First, let's discuss about use of cuffed endotracheal tubes for intubation. 1. When using a cuffed endotracheal tube, ETT, in infants and children, it is important to carefully select the tube size, ensure proper placement, and monitor cuff inflation pressure, which should typically remain below 20 to 25 centimeters H2O. 2. Opting for cuffed endotracheal tubes instead of uncuffed ones is a sensible approach when intubating infants and children. Next, let's discuss about use of cricoid pressure during intubation. 1. Applying cricoid pressure as a routine measure to decrease the chance of regurgitation is not advised during bag mask ventilation for infants and children. 2. The regular application of cricoid pressure is not advised when performing tracheal intubation in infants and children. 3. If cricoid pressure obstructs ventilation or hinders the speed or ease of tracheal intubation in infants and children, it should be discontinued. Next, let's see about atropine use for emergency intubation. 1. Administering atropine as a pre-medication can be considered to help prevent bradycardia in infants and children undergoing emergency intubation. 2. When atropine is administered as a pre-medication for emergency intubation in infants and children, a dosage of 0.02 milligrams per kilogram without a minimum dose can be considered. Next, let's discuss about monitoring exhaled CO2 in patients with advanced airways. 1. In every setting, confirmation of endotracheal tube placement in infants and children with a perfusing rhythm should involve the use of exhaled CO2 detection, either through a colorimetric detector or capnography. 2. For infants and children who have a perfusing rhythm and an endotracheal tube in place, monitoring exhaled CO2 using a colorimetric detector or capnography during both out-of-hospital and intra-hospital transport is advantageous. Bradycardia in children is rarely just a slow heart rate. It's a warning sign of impending cardiac arrest. The 2025 guidelines emphasize rapid assessment, high-quality oxygenation and ventilation, and immediate treatment of reversible causes. Before going into AHA 2025 updates in bradycardia, let's see about the pediatric bradycardia with a PULS algorithm. Bradycardia in children is treated as a physiology-driven emergency, and this algorithm guides clinicians through a structured, rapid sequence of decisions. If bradycardia persists and the child remains unstable, clinicians escalate quickly. The algorithm states, start CPR if HR less than 60, and proceed with IV or IO access, epinephrine, and atropine when indicated. Pacing is considered if medications fail. Throughout, the algorithm reinforces continuous reassessment. Check pulse every 2 minutes. Pulse present? If the pulse is lost, the team transitions immediately to the pediatric cardiac arrest algorithm. We will be doing another video in detail about the algorithms later. Let's see the bradycardia-related updates. In this, we're going to discuss about management of bradycardia with cardiopulmonary compromise. 1. Atropine is advised for infants and children experiencing bradycardia with cardiopulmonary compromise resulting from increased vagal tone or atrioventricular conduction block, provided these conditions are not caused by factors like hypoxia. 2. If an infant or child has a heart rate below 60 beats per minute and shows signs of cardiopulmonary compromise, even after effective oxygen ventilation, initiate CPR. 3. If bradycardia and cardiopulmonary compromise continue in infants and children after addressing reversible causes such as hypoxia, administer epinephrine intravenously or intraosseously. 4. Emergency transcutaneous pacing can be an option for infants and children experiencing bradycardia and cardiopulmonary compromise as a result of complete heart block or sinus node dysfunction that does not respond to CPR. Next is tachyarrhythmias. Tachyarrhythmias in children demand rapid recognition and decisive action. The 2025 guidelines emphasize distinguishing between narrow and wide complex rhythms, assessing perfusion and treating the child's physiology, not just the number on the monitor. Before going into the updates about tachyarrhythmias, let's have a quick look about the updated pediatric tachycardia with a pulse algorithm. This algorithm guides clinicians through the rapid evaluation of a child with a suspected tachyarrhythmia, beginning with rhythm recognition and physiologic assessment. It highlights that probable supraventricular tachycardia is suggested when P waves are absent or abnormal, RR interval not variable, infant rate usually greater than 220 per minute, child rate usually greater than 180 per minute, a pattern that helps distinguish SVT from sinus tachycardia. Now, let's discuss about treatment of supraventricular tachycardia with a pulse. 1. For infants and children experiencing SVT who do not show signs of cardiopulmonary compromise, it is advisable to begin with vagal stimulation. 2. If intravenous or intraosseous access is easily attainable, adenosine is advised for managing supraventricular tachycardia, or SVT, in both infants and children. 3. For infants and children who are not experiencing cardiopulmonary compromise and whose supraventricular tachycardia, or SVT, does not respond to vagal maneuvers and intravenous adenosine, it is advisable to seek expert consultation. 4. For infants and children experiencing SVT alongside cardiopulmonary compromise, it is appropriate to initiate electrical synchronized cardioversion at a starting dose of 0.5 to 1 J per kilogram. If the initial attempt is not successful, the dose should be increased to 2J per kilogram. 5. If infants and children with SVT and cardiopulmonary compromise do not respond to vagal maneuvers, adenosine, or synchronized electrical cardioversion, and expert consultation cannot be obtained, it may be appropriate to consider intravenous procainamide, amiodarone, or sotalol as treatment options. Next, let's see about treatment of wide complex tachycardia with a pulse. 1. For infants and children experiencing wide complex tachycardia who are stable and show no signs of cardiopulmonary compromise, it is advisable to seek expert consultation before proceeding with the use of antiarrhythmic medications. 2. For infants and children presenting with wide complex tachycardia that is regular and monomorphic but without signs of cardiopulmonary compromise, adenosine may be considered as a treatment option alongside expert consultation. 3. For infants and children experiencing wide complex tachycardia accompanied by cardiopulmonary compromise, it is appropriate to initiate electrical synchronized cardioversion at a starting dose of 0.5 to 1 J per kilogram. If the initial attempt is not successful, the dose should be increased to 2 J per kilogram. So, what about the AHA 2025 updates regarding treatment of myocarditis and cardiomyopathy? Myocarditis and cardiomyopathy can turn a child's heart from a reliable pump into a failing engine with little warning. The 2025 guidelines emphasize early recognition, gentle hemodynamic support, and avoiding therapies that worsen myocardial stress. 1. Infants and children with myocarditis who show arrhythmias, heart block, ST changes, or low cardiac output should be considered early for ICU transfer. 2. In infants and children experiencing myocarditis or cardiomyopathy with persistent low cardiac output that does not respond to standard treatments, ECMO or mechanical cardiac support may be advantageous for maintaining end organ function and reducing the risk of cardiac arrest. 3. For infants and children with myocarditis or cardiomyopathy who experience cardiac arrest, initiating eCPR at an early stage is a reasonable approach. 4. For infants and children with myocarditis or cardiomyopathy with persistent low cardiac output that does not respond to treatment, it is advisable to consider early transfer to a facility equipped with ECMO or mechanical circulatory support when possible. Next, let's discuss about resuscitation of patients with single ventricle congenital heart disease. Resuscitating a child with single ventricle physiology is a race against physiology itself. These patients depend on a delicate balance between systemic and pulmonary blood flow, and even small changes in oxygenation, ventilation, or vascular resistance can collapse that balance. The 2025 guidelines emphasize tailored interventions, avoiding routine maneuvers that may be harmful, supporting the circulation they actually have, and recognizing when specialized strategies or surgical pathways must guide care. In single ventricle emergencies, success comes from understanding the anatomy, protecting the physiology, and acting with precision. Now, let's see the updates. 1. For infants and children with aortal pulmonary shunt-dependent congenital heart disease who have confirmed or suspected shunt obstruction, it is advisable to promptly arrange transfer to a facility equipped with advanced cardiac therapies, such as cardiac catheterization, cardiac surgery, or ECMO, if these services are not accessible locally. 2. For infants and children with single ventricle congenital heart disease who have undergone initial palliative procedures such as stage 1 Norwood, hybrid procedure, or Blalock-Thomas-Taussig shunt, rapid initiation of eCPR during cardiac arrest can serve as an effective intervention to facilitate return of circulation. 3. For infants and children with congenital heart disease reliant on an aortopulmonary shunt who have confirmed or suspected shunt obstruction, it is appropriate to provide oxygen, vasoactive medications, and heparin as part of preparation for either catheter-based or surgical intervention. 4. For infants and children with single ventricle congenital heart disease who have undergone stage 1 Norwood, hybrid procedure, or Blalock-Thomas-Taussig shunt, rapid initiation of eCPR during cardiac arrest can serve as an effective intervention to facilitate return of circulation. 5. For infants and children with single ventricle congenital heart disease who have undergone stage 2 bidirectional Glenn or Hemi-Fontan or stage 3 Fontan palliation, rapid initiation of ECMO can be considered as a therapeutic option for managing low cardiac output syndrome. Next, let's see about management of pulmonary hypertension. Pulmonary hypertension in children is a fragile, high-risk state where even small changes in oxygenation, ventilation, or hemodynamics can trigger rapid decompensation. The 2025 guidelines emphasize preventing pulmonary hypertensive crises through meticulous control of oxygen, ventilation, acid-base balance, and sedation. First, let's see about management of infants and children at risk for pulmonary hypertensive crises. For infants and children at risk of pulmonary hypertensive crises, it is important to ensure vigilant respiratory care and continuous monitoring to prevent the occurrence of hypoxia and acidosis. For infants and children receiving mechanical ventilation who are at risk of pulmonary hypertensive crises, ensure the administration of sufficient analgesia, sedation, and neuromuscular blocking agents. For infants and children susceptible to pulmonary hypertensive crises, it is important to prevent dehydration, excessive fluid intake, and anemia. Next, let's see about treatment of infants and children with pulmonary hypertensive crises. For infants and children experiencing pulmonary hypertensive crises or acute right-sided heart failure due to elevated pulmonary vascular resistance, inhaled nitric oxide or prostacyclin is recommended as the first-line pulmonary vasodilator therapy. In the initial management of infants and children experiencing pulmonary hypertensive crises, providing supplemental oxygen and inducing alkalosis, either by hyperventilation or administering alkalizing agents, can be beneficial, particularly while pulmonary vasodilators are being given. ECMO may be an option for infants and children with refractory pulmonary hypertension who show signs of low cardiac output or severe respiratory failure even after receiving the best possible medical treatment. Next, let's discuss about pulmonary hypertension-specific therapies and interventions. For infants and children with pulmonary hypertension who suffer cardiac arrest, it remains unclear whether incorporating pulmonary hypertension-targeted treatments during CPR leads to better outcomes than traditional CPR alone. Finally, in 2025 AHA PALS updates, let's see about management of traumatic cardiac arrest. For infants and children experiencing traumatic cardiac arrest, it is advised to assess and manage reversible causes, including hemorrhage, tension pneumothorax, and pericardial tamponade. For infants and children experiencing traumatic cardiac arrest due to penetrating thoracic injury and a brief transport time, performing a resuscitative thoracotomy may be considered appropriate. As we close out the 2025 AHA and AAP Pediatric Advanced Cardiac Life Support updates, one message stands out. Pediatric resuscitation is evolving, becoming more precise, more physiologic, and more centered on the child and family. These updates refine how we recognize instability, how we intervene in the first critical minutes, and how we support recovery long after the pulse returns. Whether you're at the bedside, in the classroom, or leading a resuscitation team, staying current isn't just about guidelines. It's about giving every child their best chance at survival and meaningful recovery. Thank you for learning, for leading, and for showing up for kids when it matters most. If this breakdown helped you, make sure to like, subscribe, and share so more clinicians can stay sharp and save lives. I'll see you in the next video.